Type 1 diabetes mellitus is caused by an autoinflammatory or viral destruction of the beta cells of the endocrine pancreas, which synthesize insulin. Destruction results in insulin deficiency. It usually has an onset in childhood or adolescence, compared to type 2 diabetes mellitus, which commonly presents in adulthood. Insulin is the essential treatment, and oral hyperglycemics will not work since they require functional beta islet cells. In type 2 diabetes mellitus, instead we have functional beta islet cells, so we can use oral hypoglycemics. For type 1 diabetes mellitus, we have a genetic predisposition, even if it's weak, unlike in type 2 diabetes mellitus. In type 1 diabetes, we have anyway an association with HLA-DR3 and HLA-DR4. Histologically, in type 1, we see an islet leukocyte infiltrate, which is, however, not seen in type 2 diabetes. An important complication of type 1 diabetes is diabetic ketoacidosis. It can also occur in type 2 diabetes mellitus, but it's more common to have hyperglycemic non-ketotic acidosis in type 2 diabetes patients. DKA is often precipitated by increased stress, infection, or non-compliance with medications, diet, or trauma. In diabetic patients, a complete lack of insulin production or a relative insulin deficiency leads to the use of fats as a significant energy source. Ketosis is an increase in fatty acid metabolism to produce ketone bodies, namely beta-hydroxybutyrate, which is the major one, and acetoacetate as an alternative fuel source. In DKA, hyperglycemia induces a profound osmotic diuresis, which causes water and electrolyte loss, especially potassium. We have a metabolic acidosis, which forces hydrogen ions into cells, which displaces potassium ions that are subsequently lost in urine. This is the cause of this electrolyte and potassium loss due to metabolic acidosis. We have a mnemonic, which is remember the 3 Ks or lose AOA. It can be used to remember the clinical hallmarks of DKA. So the 3 Ks are co-small respirations, rapid deep breathing, elevated ketones in the urine and blood, and K plus potassium elevated in the serum due to electrolyte shift, although total body potassium is depleted. Then remember the 3 Ks or lose AOA, so we have lose loss, severe water loss, leading to dehydration and hypotension, positive anion gap, AOA, the anion gap, fruity odor on breath, and abdominal pain. So, which are the severe complications of DKA? We have heart failure and or arrhythmias, cerebral edema, and mucorsinusitis, which is a fatal fungal infection. So remember, severe complications include heart failure, cerebral edema, and mucorsinusitis. The treatment of DKA includes normal saline fluid resuscitation in order to correct fluid deficit, so rehydration, and reduce plasma osmolarity. Potassium and insulin are given along with glucose to prevent the patient from becoming hypoglycemic. So, saline fluid resuscitation, potassium and insulin, and glucose also to prevent hypoglycemia.